So what do you mean by gestation period? So gestation period is between the conception and the birth of baby, during which the fetus grows and develops in the uterus. So from the date of conception till the delivery date, whether it may be term or preterm, it is called gestation. So as soon as the baby is born, what we assess is the gestational age of the baby. Or when we ask the question to the obstetricians during resuscitation, what baby we are receiving? So what we are asking them is the gestational age. What is the age from the conception till the date they are planning the delivery, or the LMP, what you call it. So there are traditional ways of assessing LMP. Based on LMP, you can use the gestational age that will give your EDD. Okay. So traditional way is your 37 weeks through 41 weeks. So this is the normal way of calculating based on your last menstrual period. Okay. So based on this, how do you calculate? How do you decide the term baby as? So how do you classify the term baby from 37 to 42 weeks? It can be classified into early term, full term, late term, and post term. So early term is 37 to 38, 39 to 40 weeks, 40 plus 6, and 41 to 41 plus 6. Okay. So this is late term, and more than 42 weeks only there are post term. So why we need to assess this gestational ages? So it is very important. Certain problems are very specific to preterm babies, or we have to calculate the fluid requirement, or certain PDA treatment. All these things are very specific to preterm babies, and some problems are specific to the post-term babies also. So that's why gestational age assessment is very important. So how do you assess the prenatal assessment of gestational age? Before delivery only, how do you assess is by Nagel's rule. So as we know, that is by 280 days or 40 weeks from the first day of last menstrual period. Okay. So this rule assumes that the woman ovulates on day 14 and she has a regular 28-day menstrual cycle. So this is one of the oldest way of calculating your gestational age prenatally. So prenatally, this is the last menstrual period. Another thing is by quickening, the date of quickening. That's how you assess. So just remember the only the names: prenatal assessment, and after birth, how do you assess the gestational age? So this is one method of assessment of during prenatal age. One is last menstrual period, and other things are the day of when the quickening is felt. And other thing is when ultrasound, when do you detect the fetal heart tones? That is appearance of fetal heart tones, which can be detected with Doppler at 9 to 12 weeks of gestation. And quickening is usually felt between 16 to 20 weeks. Based on quickening, based on the ultrasound detection of Doppler waves, that's how you tell. And other thing is symphysiofundal height. Okay. So, these are the measurements that you have to take prenatally. Okay. So these are the crude ways. So what are the laboratory parameters that can be used to measure gestation is? One is lecithin sphingomyelin ratio or amniotic fluid creatinine ratio. Just remember the names of this. Okay. So just remember the names. Don't need to do. And other thing is ultrasound. Ultrasound, how do you calculate the gestational ages? In first trimester, gestational sac. Gestational sac length predicts the gestational age. And other till 7 weeks. And after 7 to 12 weeks, you use crown rump length. Okay. And then in second trimester and all, biparietal diameter is the better predictor of gestational age. Okay. Third trimester, the growth rate falls and biparietal diameter shows much greater variation. Okay. So most accurate is your first trimester scan. Up to 7 weeks, it is gestational sac, size of the gestational sac. From 7 to 12 weeks, it is your crown rump length. So this is your antenatal, that is prenatal assessment of gestational age. So okay, gestational age can be a definition, and what is the term babies and all, how do you classify the term babies, and what do you mean by gestational age, you should know from conception till the delivery. Okay, till the day of birth, that is called the period of gestation. And then how do you assess gestational age is by prenatal assessment of gestational age. Another one is after birth, how do you assess gestational age? Prenatal assessment of gestational age is by, one is based on last menstrual period, that is Nagel's rule, that is 280 days or 40 weeks. Okay. And then is other preclinical data like day of quickening and date of fetal heart tones by detected by ultrasound Doppler, and symphysiofundal height measurement. And then is laboratory parameters like lecithin sphingomyelin ratio and amniotic fluid creatinine concentration. So all this requires amniotic fluid analysis. Okay. Suppose for any other reason you are doing an amniocentesis and all, you can just send this lecithin sphingomyelin ratio to accurately guess the gestation. That is how what it means. It doesn't mean that you have to take an amniocentesis for gestational age assessment. Okay. And apart from that is ultrasound scan, first trimester till 5 to 7 weeks gestational sac, and from 7 to 12 weeks it is crown rump length, and then subsequently biparietal diameter. Okay, the farther it goes from the first trimester, the less accurate is the measurement. Okay, so all this is prenatal assessment. Now come to postnatal assessment. So once the baby is born, suppose the mother is not aware of her gestational age, what we usually only thing we know is extended new Ballard scoring system. Okay, so that is what is routinely used in our hospital and all routinely. So we should know the other names also, at least names of other ways of gestational assessment, not necessarily completely in detail. Okay, so one most commonly or most traditionally used thing is anterior lens capsule vascularity. So lens is totally vascular in the fetus. So then slowly it becomes avascular. Okay, if there is persistence of vascularity in the posterior pole, that is called PPHV, persistent primary hyperplastic vitreous. Okay, so that is another thing. So in earlier days, it is completely vascular. The lens is completely vascular, and between 27 to 34 weeks of gestation, there is gradual disappearance. So before 27 weeks, we cannot use this vascularity. And after 34 weeks, we will be certainly sure once the vascularity disappears, we can be certainly sure that it is beyond 34 weeks. So this is one method of screening. So when this should be done, as soon as the baby is born, first day only, we have to dilate and see the baby. If it is preterm, like 28 weeks, 30 weeks, we don't know. So how much is the disappearance of vascularity? That's how we can give the gestation. Okay. So there is no need to remember all these things. Just remember the name, anterior capsular vascularity of lens. Okay, so that is one way. Other thing is physical and neurological maturity. That is Amil-Thiessen angles are there. So Amil-Thiessen method. Amil-Thiessen only describe neurological evaluation. Okay, so whereas the other things like Farr and Finstorm, they describe the physical criteria. So our Ballard is there. It is combined of Amil-Thiessen, Farr and Finstorm. So they have included everything and they have come up with Ballard. So other things are Parkin and Dubovit's method. So these are the other methods of estimation. So you just remember the name. So anterior lens capsular vascularity. Okay. So other thing is Amil-Thiessen angles. That is your passive tone and neurological evaluation by passive tone. And other thing is Farr and Finstorm and Parkin's method. Okay. So just remember the name. So Ballard, what Ballard has used is he has combined everything. So he has combined the neurological maturation and physical maturation. So then we have got your Ballard scoring system. Okay. So any doubts regarding this? So prenatal maturation estimation of gestational age, and another thing is postnatal maturation of gestational age. Okay. Prenatal is your LMP based on Nagel's formula, and then your ultrasound and other parameters like symphysiofundal height and date of quickening. These are the rough estimation. Okay, and then biochemical parameters, as I told, lecithin sphingomyelin ratio and your amniotic fluid creatinine levels. So then postnatal way of estimation is your anterior lens capsule vascularity. So it is gradually disappears from 27 to 34 weeks. If the lens is entirely vascular, you can tell confidently that it is below 27 weeks. Completely avascular, you can tell it is beyond 34 weeks. So in between 27 to 34, you have to give grading. Okay. The other things are your Parkin's method, Farr, and your Amil-Thiessen method. Okay, Finstorm, Farr, Parkin, and Amil-Thiessen. Okay, so what we commonly use is your Ballard scoring system. Okay, so Ballard scoring system, it has 6 physical maturity and 6 neurological maturity. Okay, so Ballard scoring system I will share with you. Okay, so what is the principle behind Ballard scoring system is physical maturity. They have combined from other things. They have extracted from the other things. What is the principle behind neuromuscular maturity is as the maturation progresses, there will be increase in flexor tone. Okay, and decrease in extensor tone. So flexor tone will increase and extensor tone will decrease. And how will the flexor tone will increase? It will increase from lower extremity to the upper extremity. Okay, so that's how neuromuscular maturity, angles, so all these things are there. Okay, so there are 6 neuromuscular scores, and then there are 6 physical scores. Okay, so you have to give scores about for each of these, and combined scores you have to take, and then you have to assign the gestational age. Okay, so these are each of the things we can discuss each of these. How do you assess each of these scores later? Okay, so I hope the gestational age assessment question you can write in detail. I think so you just have to write the names of the gestational age. So some of the things what you should know about Ballard score is like this is one of the interview which has been given by Ballard only. So when you should do Ballard scoring system? Okay. So when you should, what is the ideal age when you should do a Ballard scoring system? Okay. So Ballard scoring system is ideally usual time frame is 30 minutes to 96 hours. So this scoring system is valid. This is the usual time frame of 30 minutes to 96 hours. However, it can be used up to 7 days. Okay. So sometimes you get in between scores. So there are what you see Ballard scoring is exactly 25, 30, like scores are in sets of 5, 25 and 30. So there are no in between gestations. Okay. So for example, what you get in between scores, suppose you get a 27 scores, how do you assess the gestational age? So you have to remember this. Okay. So only the completed weeks you have to assign for example, 25 score is there, you have to assign 34 weeks. For example, 30 score is there, you have to give the next week, that is 36 week. In between scores, how do you decide is 2 for the previous and 2 for the next. Okay. 2 you have to give for the previous gestation, and only 2 you have to give the middle gestation, that is 34 and 36. In between you get is 35. Okay. In between scores, only 28 and 29 you give 35 weeks. Only the completed week you get the next score. You don't give just because the 29 it is nearer to 36, 29 score, you don't give 36. Okay. So this is one thing which is not given in other books. So suppose you are doing Ballard score in your, I have seen many PGs writing gestational age. Suppose that baby gets a score of 28 in your gestation, they will write 34 to 36 weeks. So it is not how it is given. So you should give the exact gestation. Okay, there is no range in gestation, 34 to 36 weeks like that. So you have to give exact gestation. Okay, so what if your gestation and your Ballard are not agreeing? Suppose there is a difference. So usually there should be accuracy of within 2 weeks of known dates. Okay, suppose they are not agreeing, then if it is beyond 2 weeks, then you should always take the Ballard scoring system. Okay, you should always take the Ballard scoring system. So what is your extended Ballard scoring system is? That will cover even the extremely premature babies. So these are the things that are not given in normal book. So this thing I'll share with you. I'll just go through this once. Okay. So once we can discuss the entire Ballard scoring system, one day before your exams, we can discuss this. So these are this is how the gestation is given. Okay. So suppose score is 15, you give 30 weeks, and score is 20, you give 32 weeks. So how is the between scores are given? Okay, next to 2 scores, you give the behind gestation only. And in between 2 scores, like 18 and 19, you give in between gestation. Only the completed score, you have to give the next gestation. Okay. So, any doubt you have in this Ballard scoring and gestational age assessment? So next question they have asked is your RH ISO immunization, which is also not very clearly given in your books, like how to manage antenatally and postnatally. Not given in your Nelson also, not given correctly in your Clarity also. Clarity only gives your non-immune high drops chapter. So even Nelson doesn't give exactly how to write answer and all. So can just write these 2 flowcharts in your exam. I'll share this article with you. This is one of the recent and very good article written by my senior Tanushree ma'am. Okay, so So this is your current updates about exactly what you require in exam, like antenatal and postnatal management of RH isoimmunization. Okay, so just remember the percentages, how much percentage isoimmunization occurs and what should be done. Okay, so these are the minimal things you should remember. Okay, so for example, incidence, what you have to discuss is nearly almost Rh negative patients, if they are alloimmunized, if they are exposed to Rh positive blood, they are almost 1.8 and 0.1 to 3%. They develop alloimmunization. For example, for example, in developed countries and developing countries, there is very much difference. Okay, so because of availability of anti-D antibodies, so there is a lot of difference between developed and developing countries. Okay, so what is best required for this is both antepartum and postpartum. Okay, so both antepartum and postpartum prophylaxis is given. So this percentage you should remember. If there is only postpartum prophylaxis is given, 1.8% will develop RH isoimmunization. For example, only postnatally you give anti-D, you don't give anti-D at 32 weeks, 1.8% still develop RH isoimmunization. Whereas if you give both postpartum and antepartum, the isoimmunization will reduce to 0.1 to 0.3%. For example, you would have seen cases where they have given second baby is born RH isoimmunized. They will tell they have received anti-D prophylaxis. You will ask history about anti-D prophylaxis. What you should ask in your jaundice patient is whether they have received both antepartum and postpartum prophylaxis. So this is what I wanted to stress in this situation. If they give only postpartum, 1.8% can still develop RH isoimmunization. If you give both antepartum and postpartum, the RH isoimmunization risk reduces to 0.1 to 0.3%. Okay. So this you remember. Okay. So without any prophylaxis, almost 14% they develop antibodies in next 6 months after pregnancy. Okay. So that will affect your subsequent pregnancy. Okay. So remember this. Without any prophylaxis, around 14%. With only postpartum, 1.8%. And with both postpartum and antepartum, the risk reduces to 0.1 to 0.3%. Okay. So this thing you have to remember. So what I want to tell is this only thing is this pathophysiology, antenatal management and postnatal management. Okay. The pathophysiology is these antibodies are produced in the mother. So they will travel through the placenta and they will go to the fetus. These are the fetal RBCs. These are the antibodies that have come from the mother, triangle thing. So then there will be binding of these antibodies to the mother fetal RBCs. And then there will be extravascular hemolysis at spleen. Okay. And what happens is there will be fetal anemia and there will be erythroblastosis. Okay. So, and what happens in marrow also, there will be destruction of RBC precursors also. So once you do your peripheral smear at birth, you may not get a increased retic count in such patients. There may be decreased RBC precursors also. Okay. Sometimes you may not get increased retic count in this. So what happens in if there is fetal erythroblastosis, there will be increased bilirubin production. Okay. And there will be extramedullary hematopoiesis that will result in hepatosplenomegaly. Severe fetal anemia will result in hydrops fetalis. And if the hydrops fetalis is not controlled, there will be intrauterine fetal death and due to cardiac failure. Okay. So this is your immune hydrops fetalis. Immune hydrops fetalis leading to death. And there will be hepatosplenomegaly. So what happens once the baby is born? In the mother, the jaundice will be handled by placenta. Once the baby is born, he will be jaundiced within 24 hours. And if not controlled, the baby will develop kernicterus. Okay. And there will be ongoing hemolysis and bone marrow suppression. Suppose the baby may present even with late onset anemia also. Suppose 2 weeks, 3 weeks, there may be low hemolysis. Even if you do double volume exchange transfusion or whatever you do, there may be antibodies that are present in the neonate. There may be slow hemolysis going on and they may present with late onset anemia even up to 1 month, 2 months also. So this is the pathophysiology of RH isoimmunization. Okay, I will share this article with you. So after this, what you have to write is your antenatal management and postnatal management. So these two flow charts you have to write. Okay, antenatal management and postnatal management. So only write the flow charts. Don't write anything else. So this will only fill your 2 to 3 pages. So what you have to do, suppose an RH negative woman presents to your ANC, first visit to ANC. So if you know that there is an RH negative woman, so what you have to do is you have to check for husband blood group. If the husband blood group is also RH negative, then you have to manage just like any other pregnancy. You need not worry about RH isoimmunization. Okay. So unless she has received an RH positive blood during her lifetime, okay, only then she might be sensitized. Otherwise, there is no chance of sensitization. Okay. Suppose if the RH husband group is RH positive, then what you have to do is ICT. So we have to monitor ICT. So if the ICT is positive, then we have to repeat her titers 4 weekly. Okay. So once the ICT is positive, then what we have to wait is whether the critical titer is reached or not. Only what is the critical titer is 1:16 is reached or not. Suppose ICT is negative, then she is not isoimmunized still. Then we have to monitor ICT only. So once the ICT is positive, we have to look at the titer. Once if she is still ICT negative, what we have to wait is whether she is getting isoimmunized or not. So every 4 weekly we have to monitor. And then at 28 weeks, we have to give a anti-D. If she is not isoimmunized, she may get isoimmunized for some micro bleeds from placenta and all. So that's why we have to give this antenatal anti-D at 28 weeks. Then after that, follow her serially. And because after giving anti-D, there is no point in measuring ICT because it will show as positive only. Okay, so because of your anti-D, it may come as positive. Okay, so and then you have to time of delivery doesn't depend anything else on RH. So routine as per routine indication. And once the baby is born, you have to check the baby's blood group. If the baby's blood group is positive, then only you give postnatal anti-D within 72 hours. So there is anti-D antenatally and postnatally you have to follow. So if she is ICT positive, then we have to wait if she has reached the critical titer or not. Only 1:16. If she has crossed 1:16, then only there will be hemolysis and anemia significantly will be going on. If she is not reached, then repeat the titers every 2 weekly till term and deliver. If she has reached any time, then we have to monitor is MCA Doppler of the neonate. If the MCA Doppler of the neonate reaches more than 1.5 multiples of median, then we have to check for whether anemia is there or not. Cardocentesis we have to do for fetal hematocrit. If the fetal hematocrit is less than 34% and gestational age is less than 34 weeks, more than 34 weeks, you have to deliver. If there is less than 34 weeks, then we have to do intrauterine transfusions. IUTs we have to give baby. Okay. We have to maintain the hematocrit till 35 weeks. We have to do this. And after 35 weeks, we can give 34 weeks antenatal steroids and deliver it. Okay. Anytime the baby develops high drops, we have to deliver it immediately. We have to monitor for high drops. Okay. So I'll tell again, if the first time the mother comes, RH negative mother comes to antenatal clinic, we have to check the husband blood group. Husband blood group is also RH negative. Then we have to manage similar as any other pregnancy. If the husband blood group is RH positive, then we have to look for ICT titer. If she is immunized, isoimmunized or not isoimmunized. If she is not isoimmunized, monitor the titer, whether if she is immunized or not every 4 weekly till 28 weeks. Document her ICT as negative at 28 weeks, then give an anti-D. If she is positive, then don't give anti-D here. Already she is isoimmunized, it will not protect. Okay, and then time of delivery as routine indication. And postnatally, if the baby is RH positive, then only you give anti-D. Okay, most important workup after baby born is your blood group of the baby. Okay, if she is isoimmunized, check her titers if she reaches 1:16 or not. If there is no rise in 1:16, then monitor the titers till term 2 weekly and deliver at term. If it reaches critical titer, then do an MCA Doppler of the neonate. Then MCA Doppler is more than 1.5 multiples of median. Then you have to check for fetal hematocrit. Okay. Then fetal hematocrit is less than 30 and the gestation is more than 34 weeks, deliver immediately. Okay, don't wait because the lung maturity has occurred. Deliver it, manage postnatally. That will come in the next flow chart. If the hematocrit is less than 30 and gestational age is less than 34 weeks, that is lung maturity has not happened, then you check whether there is high drops is there or not. If there is high drops, you have to deliver urgently after giving antenatal steroids. If there is high drops, you have to deliver immediately. Okay. And otherwise, if there is no high drops, then you have to do intrauterine transfusions till 35 weeks, till the baby has reached 35 weeks. And after that, you can deliver the baby. Okay, this is your antenatal management of your Rh negative pregnancy. So for postnatal management, so you have to write this flow chart. Okay. So postnatal management, for example, there is an Rh isoimmunized baby. The gynae people are telling that it is an Rh isoimmunized baby. So, for example, antenatally diagnosed, that is, mother is Rh negative, father is Rh positive, and mother is ICT positive. This is what routinely you will get. So there can be two situations. One situation is, so fetal USG and MCA, peak systolic velocity, suggestive of fetal anemia. There may be hydrops, may not be hydrops. Okay. So another thing is not suggestive of anemia or hydrops. There is no hydrops or anemia. Another thing is there is anemia and hydrops. So how do you approach both things? One is an very serious emergency. You have to be prepared with delivery room preparation is very, very important when there is hydrops and anemia. So in both the situations, you have to arrange the gynae people who are delivering, they should arrange O negative PRBC for double volume exchange transfusion. You have to arrange double volume exchange transfusion. How much volume is required? They have to arrange O negative PRBC because we cannot waste time after delivery for DVT. Okay. So in both the situations, arranging O negative PRBC is a priority. If there is hydrops antenatally detected, what you need is advanced neonatal resuscitation. At least 2 to 3 trained personnel, at least 2 neonatology personnel should be there. And you should prepare for abdominal thoracocentesis, abdominal and thoracocentesis. That is, you have to drain the ascitic fluid, you have to drain the pleural fluid. And after draining the thoracic fluid, you will be able to put the baby to ventilator and shift to NICU. And there will be anemia. You should not transfuse the baby, whereas you should do partial exchange. You have to remove the blood from the baby, with the diluted blood from the baby. What you have to give is PRBC. Normal in your polycythemia, what you remove is, you will remove the concentrated blood from the baby and you give a less concentrated blood, or you give the saline to the baby. That is your partial exchange. Whereas here, you will remove the baby's diluted blood and give, instead of normal saline, you will give PRBC. So once the baby's anemia is corrected, then you do DVT. Okay. So if there is no anemia or anything, you do routine resuscitation, delayed cord clamping as routinely. Then after that, send cord blood. Use the cord blood for sampling. Okay. Cord blood you have to send for hematocrit, cord bilirubin, retic count, peripheral smear, blood grouping, cross matching. So all this, use the cord blood. And then once you go to the NICU, as soon as you identify that there is an Rh isoimmunized, immediately don't wait for your bilirubin results and all. You would start phototherapy immediately. That is what cord bilirubin they take for phototherapy is around 5 milligram per deciliter. Okay, you have to start phototherapy and you have to decide DVT, whether there is anemia or there is elevated bilirubin. You have to assess for DVT criteria and you have to start DVT as early as possible. And you have to repeat serum bilirubin every 6 to 8 hourly. And you have to stop phototherapy only when 2 consecutive values are below the cutoff. Okay, so this baby has definitely a loss of iron stores and all. And then you may have to start iron supplementation and even folic acid also. Folic acid is not mentioned here. So you have to give in any hemolytic anemia, you have to start on folic acid supplementation. Okay, and then there may be delayed anemia also if the antibodies are remaining in the neonatal blood. So you may have to follow up for late anemia or delayed anemia and transfuse PRBC as per the criteria. Okay. So this is your Rh isoimmunization. Just remember the percentage of how many people can get isoimmunized. This is your pathophysiology. 3 flow charts. If you write, this much is enough. Okay. Antenatal management, and then there is postnatal management. Postnatal management, classical situation is this: Rh negative mother, Rh positive father, ICT positive. There may be hydrops and anemia, and there is no hydrops or anemia, just positive result. Both situation, arrange a O negative PRBC for DVT, because after delivery there may be sudden worsening of jaundice and all. Then if there is eye drops, there will be advanced neonatal resuscitation required, abdominal and thoracocentesis required. If there is anemia, do partial exchange. And subsequently, you have to also send immediately a cord blood, hematocrit, cord bilirubin, retic count, peripheral smear, blood grouping, cross matching. Then start phototherapy as per the indication and decide on DVT as per the indication. Repeat serum bilirubin every 6 to 8 hours. 2 times if it is below phototherapy range, you can stop phototherapy. And then start on iron and folic acid. Monitor the baby, follow up for baby any late onset anemia, and transfuse. The baby may require transfusion even in neonatal follow-up also. So, for example, when is DVT done after birth, when the baby is born? When is DVT done is either of the three. Either of one of the three is present. For example, cord serum bilirubin is more than 5, or cord hemoglobin is less than 10. Either of the thing is there, you have to do DVT. Okay, and subsequently you have to see the charts. For example, AAP chart cutoff is there. If it is a low birth weight baby or less than 35 weeks gestation, what you see is measles chart or NICE guidelines, or even you can use Billy app also. Okay, and rate of rise is more than 0.5 milligram per deciliter per hour despite phototherapy, then also you may require DVT. Okay, and apart from that is any infant with hyperbilirubinemia and features of bilirubin induced neurological damage, bind score is there at any time during the hospital stay, you have to do DVT. If there is active bind is happening, there is no role of just doing phototherapy and monitoring only under phototherapy. Okay, so this is your RH-ISO immunization. Okay, so rest of the things is not required. Maybe this is required during your practice. This article is very useful for your day-to-day practice. Read once your exam is over, can read thoroughly. Okay, so what are the adjuvant therapy you should remember? One is IVIG can be given as adjuvant therapy. For example, if it is just below exchange range, you can give IVIG, but evidence is not very conclusive. How much IVIG is to be given? 0.5 gram to 1 gram per kg per dose. Okay, so recent meta-analysis 2014, it shows that it is not very useful. Okay, the evidence shows that it is not very useful. There are two type of studies: high quality studies and low quality studies. Only in the low quality studies with high risk of bias, it has shown significant difference. So which is not very conclusive. Okay, so late onset anemia is usually very high. Okay, once around 71 to 83% during their follow-up, they will require transfusion. Okay, so very important after you do a DVT and an RH-ISO immunized baby, it's very important to have a good follow-up. Okay, so this is your RH-ISO immunization. Okay, any doubts or anything else you wanted to know, you can just text me. Okay, so after these two things, next thing I wanted to discuss is your neonatal hyperglycemia. Okay, so always you will read about hypoglycemia. So but every time in your, whether is in your entrance or in your exams, they know that you don't read and come, definitely they will ask neonatal hyperglycemia. Okay, so all of you will read hypoglycemia. So hyperglycemia is also a very important topic. Even I have experienced this in my entrance. Just this first line, they had asked question. Okay, what is the definition of hyperglycemia? Okay, and what you have to be is very crucial about the wordings also. So whole blood glucose level is 125. Okay, whole blood glucose level is what you see in the glucometer. The glucometer shows your whole blood glucose level. Okay, that is your 125, and plasma glucose values, that is more than 145. Okay, this is your lab glucose, what you send to the lab, that is your 145. Whole blood glucose level is 125. So it is lower because RBCs will utilize some sugars, so it is kept as a lower range. Okay, so where is this problem commonly encountered? So not only encountered in low birth weight preterm infants who are receiving parenteral nutrition or parenteral glucose, but is also seen in sick infants. Okay, so why do you need to identify this hyperglycemia? Is not because of any specific clinical symptoms. There are no, just like hypoglycemia presents as seizures, jitteriness, lethargy, sometimes even cardiac arrest, apnea, cyanosis are the findings of hypoglycemia. Hyperglycemia per se doesn't have any specific clinical symptoms. But why this happens is, once there is hyperglycemia, there will be hyperosmolarity. So the hyperosmolarity occurs. What will hyperosmolarity do? It will cause osmotic diuresis, and baby will go in for dehydration, weight loss, and there will be hyperviscosity, and then it may lead to cerebral hemorrhage. So severe persistent hyperglycemia can lead to cerebral hemorrhage. Okay, so what will happen is, as we know that in the formula of osmolarity, each 18 milligram per dl rise in glucose will raise the osmolarity by 1. Okay, so subsequently what happens is, because of hyperosmolarity, there will be osmotic diuresis and dehydration. Already preterm infants, they will be having large insensible fluid losses because of your warmer, radiant warmer, your convection water loss, and everything. So this again, insensible water loss will cause more dehydration in the preterm neonates. Okay, for example, if the glucose level is very high for in neonatal diabetes or in a stressed neonate or your uncontrolled IV infusion, if the dextrose is 450 to 720 mg per and all, there will be increase in osmolarity by 25 to 40 milliosmoles. And what happens when there is such high osmolarity is your blood has such high osmolarity, your water will move from intracellular to extracellular. That is your intracellular to extracellular compartment. And this will cause the contraction of your cells in the brain. The brain will shrink and this will tear your cerebral venous sinuses. And then there may be intracranial hemorrhage, for example, subdural hemorrhage or an extradural hemorrhage. This can cause contraction of the intracellular volume of brain, and that will cause intracranial hemorrhage. So that is why very important to monitor for hyperglycemia and treat hyperglycemia. Okay. So other very rare cause of your hyperglycemia is your neonatal diabetes mellitus. Okay, sometimes even neonatal age, we have seen many cases of diabetes mellitus that may present with polyuria, dehydration, and even neonatal age they have presented with decay, neonatal decay. Okay, so all these neonatal diabetes are usually genetic in origin, and which needs evaluation and genetic diagnosis and treatment. So any baby with less than 6 months or 1 year itself, you have to suspect neonatal diabetes. Not necessarily the 28 days only for neonatal diabetes cutoff. So any baby with onset of hyperglycemia, decay, less than 1 year of age. So then you have to suspect this genetic etiology of diabetes. Okay, why I'll tell you, it is very important. Okay. So what are the etiologies? First and foremost etiology is iatrogenic. You're giving more GAR. What is required for neonates, very extremely low birth weight, less than 1000 gram babies, is your only GAR is 4 to 5 milligram per kg per minute is required. Okay, and you are not using any aminoven or any protein solution. You are not using. You are giving only dextrose only during your IV, during your first few days. Then there is high chance of having hyperglycemia. Okay. And what are the drugs that cause is your glucocorticoids. Okay, so other things that are caffeine, theophylline, phenytoin, and diazoxide can also cause your hyperglycemia. So what is most important is ELBW babies. Okay, why ELBW babies is they have a very variable insulin response. So insulin response is not that much because of your hyperglycemia. In response to hyperglycemia, the pancreas may not secrete insulin to that extent. Okay, and hepatic glucose production will keep on continuing. Even though plasma insulin is there, the hepatic glucose production will not shut down. Okay. So why? Because there will be immature glycogenolysis enzymatic system in the babies. Whatever glucose is there in the blood, it may not be stored as a glycogen because of the immature glycogenolysis enzymatic system. So this is the reason why ELBW babies will have hyperglycemia. Okay, sometimes there is severe weight loss. Some baby will be 1.2 kg after 4 or 5 days because of radiant warmer. We have not kept in servo mode, and all. The baby would have shrunken to 800 grams. 1200 gram baby would have shrunken to 800 grams, almost 30%, 33% weight loss. So in such babies, we may have to administer more than 200 ml per kg as a dehydration correction. We may be giving excess fluid. Okay, so that time we have to give at least 5% dextrose. Okay, we should not give less than 5% dextrose. Okay, so then it will become hypotonic, and that will cause osmotic sudden shift in osmolarity and central point and myelinolysis, hyponatremia. All these things can occur if you give large amount of fluid and a hypotonic fluid. Okay, so when this such amount of fluid is given, there will be large glucose load, and then there will be hyperglycemia. Okay. So what we should do is we have to use incubators in such babies. We have to use humidified incubators, not just incubators, humidified incubators that decrease this water loss and need for this IV fluid to treat such babies, prevent dehydration in such babies. We have to avoid. And even lipid infusion can also cause hyperglycemia. Sepsis per se can cause stress and decrease insulin release, cytokines, endotoxins. And sepsis endotoxin can result in decreased glucose utilization, stress hormones like catecholamines, cortisol in sepsis. So what Clarity gives is, suppose if the baby if a baby is not receiving any glucose, okay, is not receiving any glucose load, normal glucose you are giving, GAR of 3, 5 or 4, still you are getting hyperglycemia. Persistently you are getting hyperglycemia, 150, 200. So always think of sepsis. Okay. So sepsis should be your prime consideration in such an infant. So, and then is stressed preterm, okay, who is requiring mechanical ventilation. You're not adequately giving pain control mechanisms. Repeatedly, you're puncturing for cannula. Okay, so there will be persistently high catecholamines in the baby. Okay, so these are all persistent alarms around the baby. So these are all your stressed preterms. Okay, so there also there will be high glucose levels. Then is hypoxia. Then is surgical procedures. Surgical procedures, there will be secretion of epinephrine, glucocorticoids, and glucagon. And there will be some anesthetist or they will be giving high glucose concentration IV fluids without any knowledge. Okay. So these are, and another thing is rare causes your neonatal diabetes mellitus. So what are the etiologies of hyperglycemia? First and foremost is definition of hyperglycemia, and what are the symptoms. There are no specific symptoms, and why we should treat hyperglycemia. We should write the reason. Okay, and what happens if there is contraction of interstellar volume in the brain. Especially brain is very important because it can cause intracranial hemorrhage. Okay, then rarely you have to think of diabetes also. Etiology, 8 etiologies you have to write. One is your iatrogenic, another one is drugs, another one is extremely low birth weight infants. Okay, lipid infusion, sepsis, and stressed preterm. Okay, and hypoxia and surgical procedures, and neonatal diabetes mellitus. Okay, so neonatal diabetes mellitus is one thing where definitely there will be increased insulin requirement persistently. If there is glucose more than 250 for 1 week, then always suspect neonatal diabetes mellitus. Always more than 250 mg per deciliter for more than 1 week, then always suspect your neonatal diabetes mellitus. So usually babies with neonatal diabetes mellitus are SGA, term SGA babies, and both male and females without any gender predilection, and they will have family history of diabetes mellitus. They will present with marked hyperglycemia, okay, and glycosuria. That is more than 240 to they may even reach 230. Your routine glucometers will always shows high. Okay, there won't be any cutoff only. So only you have to send to lab only to get the absolute value, like 1,500. What we have seen in our during my PGI days is there used to be one baby who used to have sugar recordings of 1,100 persistently, 1,100 mg per deciliter. Okay, so we have to confirm only by the lab. Always glucometers we change 3-4 watt glucometers. Everything used to show high only. Okay. So they will present with polyuria, dehydration, acidosis, ketonuria, and there will be reduced subcutaneous fat and failure to thrive. Okay. And what you can check is insulin levels and C-peptide levels. There will be almost absent or nil. Despite high glucose level, if there is no insulin secretion or no C-peptide, then it is almost sure of diagnosis of neonatal diabetes mellitus. Okay. And it may be transient or permanent. Okay. So what you are more worried is your or what you have to search is your activating mutations. Activating mutations of KCNJ11 gene that encodes for KIR 6.2 subunit or the ABCC8 gene. ABCC8 gene and KCNJ11, there will be activating mutations. Okay. So what you have to search for is these mutations are there or not. Okay. If these mutations are there, what you can use is sulfonylureas. So you can use sulfonylureas to treat neonatal diabetes. For example, glibenclamide. So glyburide. So such drugs can be used to treat neonatal diabetes mellitus. Though it is not a type 2 diabetes mellitus, if only type 1, this is purely type 1 diabetes mellitus. Because of this mutation, you can always use sulfonylurea. So suppose we are not affordable for genetic mutation analysis, what we do usually is give a trial of sulfonylurea. Whenever we suspect a neonatal diabetes mellitus, we give a trial of sulfonylurea. We'll overlap with the insulin and the sulfonylurea, and then we slowly taper the insulin, and then we see that whether it is maintaining on the sulfonylurea only. There are protocols to shift from insulin and sulfonylurea in neonatal diabetes mellitus. You need not worry about that. So it is important to screen for this mutation. If this mutation is there, then it is very simple to treat. Okay. So then if there is transient diabetes mellitus, it will recover within 6 months to 1 year. And in later age, they may develop diabetes in their adolescent or adult age. Okay. So sometimes there may be pancreatic lesions, pancreatic hypoplasia, aplasia. Okay. So there may be other congenital defects of pancreas that may result in your this thing. These are all the inherited causes. Then if you are giving hyperosmolar formula, the inappropriate dilution. Suppose somebody is not diluting like 30 ml one scoop. If they're giving 3-4 scoops in 30 ml thick feed they are giving, then it may cause hyperglycemia. Okay, then is immature development of glucose transporters. The blood glucose may not get transported within your tissues because of GLUT4 mutation. So these are, so main things are these things. These are all very rare. If you remember, you write these last 3 things. Otherwise, it is not required. Okay. To treatment, when you should treat hyperglycemia. So there are certain guidelines, like if the blood glucose is persistently any blood glucose more than 20 millimoles. 20 millimoles is 360. 1 millimoles is 18 mg per deciliter. So you have to multiply by 18. Okay. So if any glucose level more than 20 millimoles per liter, you have to treat with insulin, and persistently if it is more than 15. Okay. So that is almost, it becomes up to 250. Okay. 250 to 255. So if it is persistently more than 255 for more than 1 day, 2 days, 3 days, then you can think of treating it. Okay. And if there is persistently more than 12, 12 is around 210 with glycosuria on urinary dipstick, then you have to treat. So these are the 3 things where treatment have initiated in various studies. This is not hard and fast rule. These are taken from various guidelines and studies that have happened on hyperglycemia. Okay. So what is important is you have to decrease the GAR. Okay. So come down GAR to 4 to 6 mg per kg per minute. Even after coming down GAR, if the sugar levels are persistently more than this, then you treat. Okay. So don't use sugar solutions. Don't use, for example, D5 also you dilute, and don't dilute D5 also and give. Okay. Some people I have seen giving D5 also, they'll dilute with sterile water or NS, that is half D5 to control sugar. So that should not be done because it is hypotonic. So that should not be done. Okay. Then you should start parenteral nutrition as soon as possible. That means that amino acids you should add. So some amino acids may promote insulin secretion, and feed as soon as possible. Whenever the condition allows, feed as soon as possible, because giving feed will secrete insulinogogues from the intestine. Okay. Cholecystokinin, all these things are your intestinal hormones which will release insulin. Okay. And then is suppose small infant, they will be initially unable to tolerate GAR, but eventually they will tolerate GAR. Okay. When you should give insulin, how you should give insulin is what you should require. As I told, more than 250. Even after lowering GAR, if the insulin is more than 250, you give insulin. Okay. Then how you should give insulin is you have to dilute it and you have to prime the tubing. Okay. Most of the insulin will stick to your tubings. So you should double time, you should 2 times. Purge the IV tubing 2 times. You should load the syringe, keep it for 20 minutes so that whatever insulin sticks to the syringe borders, that is fine. And even the tubings, you have to flush the tubings 2 times so that some of the insulin gets stuck to the your tubing, IV tubing. And then once you keep for 20 minutes, then your tubing or solution is saturated with insulin, then only you put. Otherwise, it will not show response for a few hours. You are giving insulin, your dextrose is not coming down. You try to increase your insulin dose. Suddenly, after a few hours, there will be hypoglycemia. Okay. Once the tubings are all saturated, whatever insulin is there directly goes into the body. Suddenly, you will have fluctuations and hypoglycemia. So always remember this mode of insulin infusion. Okay. So 0.05 to 0.2 units per kg per hour is the dose. Okay, initially you give bolus as insulin, intermittent bolus, 0.05 to 0.1 every 4 to 6 hourly. Okay, so that bolus also is not given suddenly. Okay, intermittent bolus, what I told, is also not given suddenly in neonates, just like in adults, like subcutaneously, all these things are not given. So I have seen some people giving subcutaneous insulin. So always give IV, prepare the solution, always give IV via syringe pump over 15 minutes. Okay. So never give this insulin and also Lasix as IV bolus. Always give infusion. Okay. So this thing you remember, how much insulin to give, when to give, and how to give. Okay. And if it is remains still more than 200 after 3 intermittent bolus doses, then you give continuous infusion. So this is what protocol you have to remember and write. And check insulin level every 30 minutes until it is stable. And then if there is still more than 180, you have to increment the insulin dose 0.01 unit. And And if any time hypoglycemia occurs, stop the insulin immediately, administer 10D 2 ml per kg. And when you are giving insulin infusion, monitor potassium levels because insulin shifts the potassium, this thing inside cells. Okay. And for example, if you diagnose neonatal diabetes mellitus, then you may use subcutaneous Lispro. Okay. This is your short-acting Lispro insulin that you can use subcutaneous, not the regular insulin. Okay. So regular insulin, you should give IV administration in neonates. And then if there is mutation is seen, then you can give oral sulfonylureas. Okay. So this much is your hyperglycemia. So it is very given detailedly in your Cloharty. This is a page from Cloharty, what I taught. Okay. So I think any doubts in this topic, you can ask me. Anything you have not understood. You can read this part today only or tomorrow only when the memory is fresh. You read this and you will definitely remember in exam. You need not, once it is taught today, if you read today or tomorrow, you may need not revise till your exam day only. Okay. So read one, though you read very less, read very thoroughly. Okay. So I think we have finished new Ballard scoring system, gestational age assessment, RH isoimmunization, and your this thing. So next thing what I want to discuss is your infant of diabetic mother. Okay. So all this thing is not required. So I'll just go to the point. So I'll just directly go to the infant of diabetic mother. So what will happen is there will be persistently elevated sugar records in the mother. And what will be the fetal effects of maternal hyperglycemia, and what is the pathophysiology you should know, and what are the perinatal implications, and what are the neonatal complications, and how do you manage? So these are the 4 things we should know. Okay. So what are the fetal effects of hyperglycemia is? So that is divided into fetal effects, neonatal effects, and long-term effects. So fetal effects, what you see is your embryopathy. If there is hyperglycemia in a first trimester, for example, mother is diabetic, even before conceiving, then it is called, it causes is diabetic embryopathy. So if the mother is hyperglycemic or gestational diabetes mellitus, that is usually seen after 24 weeks or 28 weeks. So then you call it as, what it causes is diabetic fetopathy. Already the organ systems, it is beyond the embryonic period. So second and third trimester hyperglycemia will cause fetopathy. Okay. So what we see in neonatal age group is your congenital anomalies. If it occurs because of first trimester, what you see is congenital anomalies, or even you can see is growth disruption. For example, macrosomia, if it is second or third trimester. If it is an early hyperglycemia or diabetic nephropathy and all is there in mother, you can see even IUGR also as an infant of diabetic mother. Then there is surfactant inhibition, RDS can occur. Then metabolic and hematologic complications like hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia. So all these things can occur in hematological complications. And then there is long-term outcomes also. Baby may be having hypertension, cardiovascular diseases in long-term period. Okay. So HbA1c level is very much predictive. If the mother's HbA1c level is more than 12, uncontrolled diabetes during first trimester, then only there is major congenital anomalies and all will occur. Okay. Better glycemic control, decreased risk. For example, 30% reduction with every 1% decrease in HbA1c. So HbA1c in first trimester will always predict your diabetic embryopathy. Okay. So this you remember. So what happens is your diabetic embryopathy, there will be fetal hyperglycemia. So there will be more metabolism in the baby or the fetus. There will be formation of free radicals in mitochondria in susceptible tissues, and free radicals and hydrogen peroxides will be formed, and this will inhibit the prostacyclin, and there will be more of thromboxanes and other prostaglandins in the neonate, and there will be disruption of vascularization to the developing tissues, and so there will be some tissues or there will be sacral agenesis. So some tissues will not develop only because of the disruption of vascularization. This is the pathophysiology of diabetic embryopathy. Okay. So this flowchart is in Nelson, which is very, very simplified and very, very nicely given. Okay. So this flowchart you can write in infant of diabetic mother. Okay. So there will be maternal hyperglycemia. So this will result in fetal hyperglycemia. So this will result in congenital anomalies. Okay, this will be occur when congenital anomalies occur when there is hyperglycemia periconceptionally, like during ovulation, during pre pregnancy only. If she is hyperglycemic, then there will be congenital anomalies. Okay, so so 0 to 20 weeks, if there is hyperglycemia, there will be decreased growth, early growth, because insulin response will not come in the fetus. In fetus, the insulin response will come only after 20 weeks of gestation. Only after 20 weeks of gestation, if there is maternal hyperglycemia, that will elicit fetal hyperinsulinemia and fetal overgrowth. Okay. For example, here there is fetal hyperinsulinemia. So what it causes is neonatal hypoglycemia, 0 to 7 days, anytime it can occur. Then surfactant deficiency can occur, and immature liver metabolism, and it can cause jaundice, more jaundice. And the other thing is both fetal hyperglycemia and hyperinsulinemia. Only if macrosomia will occur only if it is beyond 20 weeks of gestation. So more bigger baby you will be trying to deliver in normal delivery. There will be birth asphyxia. There may be obstructive cardiomyopathy. There will be, or transient tachypnea of newborn can occur. And if there is placental vascular abnormality, fetal hypoxia can occur. This will result in polycythemia and iron abnormalities. And polycythemia can cause stroke in a neonatal age group. Okay, and then there will be long-term abnormalities. Okay, so this is the pathophysiology of your infant of diabetic mother. So fetal hyperinsulinemia will occur only when it is hyperglycemia is seen beyond 20 weeks. That's why early hyperglycemia is there. There will be more chances of congenital anomalies. So, okay, so pre-gestational diabetes, already diabetic women conceives, there is high chance of congenital anomaly, high chance of IUGR. If she is already nephropathy, retinopathy and all, vasculopathy is there, there will be placental vasculopathy also. There will be IUGR baby born to a pre-gestational diabetes mother. Only in a gestational diabetes mother beyond 20 weeks, there will be insulin response in the baby that will result in fetal macrosomia, that will result in perinatal complications and neonatal complications like hypoglycemia, surfactant deficiency, and jaundice, and other metabolic abnormalities. Okay. So this is called Peterson hypothesis. Okay. So this famous diagram is called Peterson hypothesis. Okay. So remember these complications. So what are the complications that can be seen? CNS anomalies. This is very specific for your maternal diabetes. So when this is seen, not gestational diabetes, don't expect a gestational diabetes mother beyond 24 weeks to have a CNS anomaly. Okay, this is seen in only pre-gestational diabetes. Already diabetic women conceives uncontrolled diabetes. There is high chance of anencephaly spina bifida, almost 13 to 20 times. Okay, and 200 times increased risk of caudal regression syndrome. Okay. So what is caudal regression syndrome? As I told, there will be vascular disruption. Lumbar and sacral vertebra may not be formed at all in these babies. Okay. So this is how a caudal regression syndrome. You might have seen in your delivery time, such babies would have delivered, but you don't know the diagnosis. This is when the sacral and the lumbar vertebra are not developed. This is genu recurvatum. We will only take orthopedic referral for such patients. Whereas these are the patients when there was pre-gestational diabetes. This is anencephaly. This is your caudal regression. Okay. And cardiovascular anomalies. And there is hypertrophic cardiomyopathy. It can cause of thick interventricular septum, LV outlet obstruction may occur, and they may present with respiratory distress, poor cardiac output, and even heart failure. Chest X-ray may show cardiomegaly. It is best diagnosed by echocardiography. Okay, and what you must remember is this cardiomyopathy is transient. Okay, as soon as the fetal insulin comes down, the cardiac chamber size and all comes down within 6 to 12 months. Okay, so this is CNS anomaly. This is your anencephaly and caudal regression syndrome. Anencephaly spina bifida 13 to 20 times. Caudal regression 200 times increased. Okay. So cardiovascular anomaly we got to know. So that is in gestational diabetes mellitus. If it is first trimester only, there is more risk of congenital malformations. What are the congenital malformations? TGA. What you should remember in a diabetic woman conceiving is TGA. TGA is very specific to your pre-gestational diabetes mother. Other things are ASD, VSD, and aortic coarctation. Okay. So these are your TGA and ASD, VSD. Okay. So this you can see aorta arising from the right ventricle and pulmonary artery arising from the left ventricle. Okay. So this is how the hypertrophic cardiomyopathy looks. There is a very less chamber to accommodate blood volume. Okay. The baby may present with respiratory distress first few days without any cause, without any pneumonia or RDS, may present with respiratory distress just because of this hypertrophic cardiomyopathy. Okay. So already we have seen what are the gastrointestinal anomalies. Small left colon syndrome. So it usually spontaneously resolves. Okay. And other things are duodenal atresia, imperforate anus, situs inversus. Genitourinary anomalies are also seen. Ureteric duplication, renal agenesis, and all. So what we may see is situs inversus. This is your small left colon. Just remember the photos. You remember write these names in your exam. Okay. So what you see is macrosomia. Macrosomia is 4 times more common, whereas IUGR is more common with vasculopathy. If there is vasculopathy, for example, preeclampsia is there, along with GDM, mother has preeclampsia and placental insufficiency, you get an IUGR. Okay. And there is aggressive glucose control. Tight glucose control also will result in IUGR. So, why macrosomia, as I told, maternal hyperglycemia, fetal hyperinsulinemia, there is accelerated utilization and more growth. Okay. So fetal hyperinsulinemia, insulin is an anabolic hormone that will result in growth. Accelerated body mass accretion will be there. Visceral organ hypertrophy will be there. More adipose tissue deposition, more in the back and shoulder region. That is very important. There will be more fat deposition in the shoulder region. That's why these babies will have shoulder dystocia and more chance of brachial plexus palsy and birth asphyxia. Okay. So all these things you need not know. What are the perinatal complications? As I told, perinatal mortality is very high because of congenital anomalies, and birth injury is also very high. Neonatal morbidities are polycythemia and hyperviscosity, hypoglycemia, hyperbilirubinemia, hypertrophic and congestive cardiomyopathy, RDS. All these things can occur in your neonatal age group. Okay. So preterm delivery can occur and perinatal asphyxia can occur. These are the perinatal complications. Birth trauma is very high. Why shoulder dystocia? As I told, more fat deposition in your trunk and your shoulder region. Okay. So that's why there is shoulder dystocia. So 1/3 of IDMs are more than 4,000 gram and there is 1.7 times greater risk. So there is distribution of fat in the shoulders and the upper back. So all these injuries can occur. Brachial plexus injury can occur. Clavicular fracture can occur. Humeral fracture can occur. Cephalhematomas. If there is forceps delivery, there may be subgaleal hemorrhage or venous delivery, subgaleal and subdural hemorrhage, and facial palsy can occur because of forceps application. Facial nerve injury can occur, and it will lead to frequent cesarean section deliveries. Okay. So these are some of the things that can occur. Okay. So this is your brachial plexus injury. This is a polycythemic infant. What you can see is your venous delivery causing a cephalhematoma. Okay. And why it causes RDS or TTNB is your delayed maturation of surfactant. Okay. Lung maturation is interfered. And post natally, what you can see is hypocalcemia usually occurs in 24 to 72 hours. Why this occurs is due to low PTH. So almost occurs in around 30% of your IDMs. You should write the percentage. Even Cloherty gives around 3 to 4 pages of IDM. Okay. So why it occurs is due to low parathyroid hormone in infant. And why it occurs is because of high maternal calcium. There will be high maternal calcium that has caused low parathyroid hormone in the infant. Parathyroid is suppressed in the infant because of maternal hypercalcemia. Okay. So usually asymptomatic, it means that there will be self-resolution, or it may present as jitteriness, tachypnea, seizure, or tetany, or lethargy, or apnea. Once you identify, treat with IV calcium. Okay, for 72 hours. Hypomagnesemia occurs in around 40% of IDMs. Why it causes? Because of renal losses. Okay. And usually it is transient and asymptomatic. Treat if there is hypocalcemia alone. Hypomagnesemia alone don't treat. Only if it is causing hypocalcemia, then you treat. Okay. Hypoglycemia is seen in 27% and it can occur first few hours of life. That's why first 24 hours is very, very important. So why it occurs? Because of hyperinsulinemia. So the reason is you just write why it, how much percentage it occurs, when it occurs, and why it occurs. And transient resolves in 2 to 4 days, whereas permanent, if it is there, then it may occur for few months to weeks also. Okay. So this is the classical feature of hypoglycemic brain injury. If you don't screen, screen these neonates, there will be a parieto-occipital area. There will be involvement of brain damage that can result in very bad CP or a visually impaired child. Okay. So other things are hematological complications like polycythemia and hyperbilirubinemia. Polycythemia occurs in 13 to 33%. Why it occurs? Because of erythropoietin, increased erythropoietin because of chronic fetal hypoxia. Okay. And if there is polycythemia, it causes hyperviscosity syndrome, vascular sludging, infarction. And so when you should do is you should consider hematocrit around 6 to 12 hours after birth. You have to do hematocrit and you have to intervene if there is symptoms with more than 65 or asymptomatic more than 75. Any standard guidelines you have to follow for polycythemia. And hyperbilirubinemia, why hyperbilirubinemia occurs? Mainly because of cephalohematoma or polycythemia or any bruises because of birth injury or any fracture that has occurred or per se prematurity, late preterm delivery can result in increased bilirubin or hemolysis that can result in hyperbilirubinemia. Okay. So what are the long-term metabolic complications are? Type 1 diabetes are more common. Type 2 diabetes also can occur. And usually BMIs are higher in infant of diabetic mother than controls. Okay. But usually macrosomia comes down. Like one of my friends' baby was born at 4.2 kg. At birth, it was looking more bigger than current what age. It is at 6 to 8 months of age. They usually macrosomia resolves. But after that, obesity usually recurs. Okay. There will be recurrence of obesity in early toddler age group. So management is delivery. You have to, at delivery, you have to always consider this as high risk delivery. Okay. Is the screen visible now? I think somebody had messaged me. So always consider this IDMs as high risk delivery for both mother and infant, and you have to follow standard basic steps of resuscitation. Okay. And this is not required. You have to avoid insulin glucose infusion in the mother. So this is not required. Forced delivery, you have to observe for any asphyxia, birth injury. You have to screen for brachial plexus injury, any malformations are there or not, and what is the macrosomic status, and any hypoglycemia is there, any RDS is there. Always you should screen for this. Okay. So such large baby with hairy pinna, and there will be more hair on the face. Okay. The head size will be normal, and whereas the shoulder and the body will be very large, and their baby will be plethoric, puffy, and there will be fat pads over the upper back. Okay. So these are some of the indications that it is an IDM baby. These are the things you should screen. So how do you manage this? So you have to work up. The management depends on the clinical presentation. If there is hypoglycemia, early feeding and IV fluids. And symptomatic electrolyte abnormalities, you have to give those electrolytes. Like hypocalcemia, treat hypocalcemia. Hypomagnesemia, you treat hypomagnesemia. Okay. So you have to do is for if there is respiratory distress, you have to provide cardiopulmonary support. Do a chest X-ray, echo to search for the cause. Give phototherapy. If there is polycythemia, you give IV for hydration, exchange transfusion. If there is anomalies and all, you have to do imaging studies and you have to take specialist consult. So this is one chart that summarizes the management. So each of the things you can take up in management of IDM. Okay. So I'll share with you with this PPT also. So IDM also has been asked in your exams. Okay. So I think it is. So if you have stamina, we can do one more topic, or else we can do tomorrow. So depends on you people. So what do you want to do? So you want to discuss one more topic? Okay. So what we can discuss is your, I think, apnea of prematurity. That is one thing that has been asked. So this is very brief. I think 5 to 10 minutes I can finish this topic. So apnea of prematurity. So key points. So definition, like what you traditionally write the definition, that has been slightly changed. Like can still follow the same definition, like cessation of breathing. So cessation of breathing for more than 20 seconds. or less than more than 10 seconds if it is associated with bradycardia. Okay, so that's that things you can still holds good, but clarity in this new recent edition try to follow this definition. Okay, the apnea is defined as cessation of airflow. So it is not always classically there will be cessation of breathing. Just to accommodate obstructive apnea, they have changed this definition. Okay, so in obstructive apnea there will be breathing is there. Okay, so there will be just airflow will be obstructed. So that also you should include in this definition. That's why apnea is defined as cessation of airflow. Okay. So when it is pathological, when the absence of airflow is accompanied by bradycardia, that is heart rate less than 100 per minute, or hypoxemia, that is saturation, which is clinically detected by cyanosis, or an oxygen saturation less than 80%, and there is hypotonia or pallor, then only you call this as a pathological apneic spell. Okay. So whenever we see a baby which is just stopped breathing, it will not be present. Only after a prolonged apneic episode, there will be initially desaturation, bradycardia, then later on baby will be hypotonic, and suddenly there will be pallor. Okay. And usually bradycardia and desaturations are seen after 20 seconds of apnea. Okay. Whereas in premature infants, it may occur more rapidly. So that's why they have strictly not kept the definition as more than 20 seconds and 10 seconds like old definition. So you can write this new definition. Okay. So apnea is defined as cessation of airflow. So what they give a line is bradycardia and desaturation usually present after 20 seconds of apnea. And although typically it may occur earlier in a premature infant, even 10 seconds, 15 seconds in a premature infant, it can cause desaturation and bradycardia. Okay. So lastly, as the spell continues, you have not monitored the baby is continuously having apnea. Later he may present with hypotonia, that is not responsive, not moving, and then pallor can occur. Pallor and hypotonia are the last manifestation, and then the infant may remain unresponsive to tactile stimulation. Initially, if you see when there is cyanosis and desaturation, it may respond to tactile stimulation. When the baby goes into hypotonia and pallor, it means that it is already in an advanced stage and it will not respond to your tactile stimulation. Okay. So what level of desaturation, how much level of desaturation or bradycardia that will cause neurodevelopmental impairment, it is still not known. Okay. Suppose some baby you have seen apneic for like after 1 minute or 2 minutes and it has come back, whether there will be neurological sequelae or not, we don't know. Okay. So how do you classify apnea is whether there is efforts or not, and upper airway obstruction is there or not. Whether during your apnea, you should always see whether the baby is breathing, has any efforts there or not. Okay. So if there is efforts and the baby is breathing, it is obstructive apnea. If the baby has no effort, then it is central apnea. Okay. So, so usually obstruction will be at the pharyngeal level. Okay. Pharyngeal weakness, it will cause because of prematurity, there will be obstruction or there will be secretions. Mixed apnea is when airway obstruction with inspiratory efforts precedes or follows central apnea. There will be either central apnea occurring before or after an obstructive apnea. So there will be both components of obstruction and cessation of breathing. Okay. So most common variety is mixed apnea. What you see is mixed apnea. Okay. So this is the most common variety. So how much is the incidence? Less than 28 weeks, almost all will have apnea, and more than 28 weeks, around 25% will have apnea. Okay. So less than 28 weeks, more than 28 weeks, you can remember. Okay. So onset is usually seen in first 7 days of life. Okay. So 2 to 7 days. So sometimes what you previous books gives is usually 2 to 7 days. First day at birth, it cannot happen like that. So sometimes because of respiratory distress, if there is hypoxia, not adequately managed respiratory distress, these apneic spells can occur even at birth. Okay. So what we are discussing here is apnea, not apnea of prematurity. Okay. So you have to remember this. Okay. Previously, what the chapters were like apnea of prematurity and all. What we are discussing here is apnea, broader apnea. It can occur due to any cause. So if you rule out all the other pathological causes, then only you can label it as apnea of prematurity. Even premature infants can have other pathological causes, which we'll discuss later. So sometimes in premature infants, if the RDS is not managed properly, baby is hypoxic, persistently hypoxic. Okay, there will be atelectasis. It's an apneic episodes can occur even at birth also. And if first 7 days, it will, if they don't occur, they are unlikely to occur later. Okay. Duration, if the babies are before 28 weeks born, apnea can continue even beyond term also. Otherwise, 34 to 37 weeks, it stops at 34 to 37 weeks of post-menstrual age. Okay. Whereas in less than 28 weeks child, it may continue even beyond term also. Longest they have documented is even at 43 weeks. Okay. Longest is 43 weeks they have documented. So sometimes even they may ask this question in your Viva also. If you tell about apnea of prematurity, till when longest you may record apnea, because if you answer all questions very well, everything, then such questions may come in your Viva, in your case discussion of neonates also. Okay. So term infants can also have apneic spells. Okay. And always in term infants, you should always consider an abnormal cause. There will be always serious identifiable causes such as birth asphyxia, intracranial hemorrhage, seizure, or a medication use like phenobarbital overdose. So this is what we commonly see. Okay. And if there is apnea, if in the absence of drug depression or asphyxia, you have to consider CNS anomaly. Okay. So if there is apnea in absence of any drug usage or asphyxia and other things, or IVH, then you have to consider a serious structural CNS anomaly. Okay. So what is the pathophysiology of apnea of prematurity? Here they use apnea of prematurity. Specifically, there is pathophysiology only for this apnea of prematurity. The other things are all pathological. Okay. So other things are all, why apnea of prematurity occurs? Because of developmental immaturity to central respiratory drive and peripheral chemoreceptors. You just write the points. Okay. So brain immaturity, as we know, the drive itself is very less in this premature infants. So there will be brainstem neural function will be abnormal. How do you identify this brainstem neural function is abnormal? What you can do, they have done is BERA. The BERA waveforms they have checked. In between waveforms, the duration and all are very wide in a preterm unit. Okay. So the duration, the conduction duration shortens as the gestation increases. That's how they have seen that the brainstem matures, the apnea has come down. And then is REM sleep. Okay. So active REM sleep is marked by irregularity of tidal volume and respiratory frequency. So preterms, they will have predominantly REM sleep. So that's why more often preterms will have apnea in the state of sleep. So predominantly REM sleep is more in preterms, and developmental immaturity of respiratory drive. These are two things. Then is chemoreceptor response. So there will be inappropriate response of chemoreceptors because of hypercapnia. Okay, there will be no response to your CO2 elevation. Okay. So ventilative response to increased carbon dioxide is decreased in preterm infants with apnea compared to match group without apnea. Okay. So this is one thing you have to write. The chemoreceptors, peripheral chemoreceptors and central chemoreceptors, both are not very responsive. Then his reflexes are very active. In the pharyngeal reflexes are very active. For example, any fluid or anything in the pharynx, for example, putting a milk into the pharynx, that may cause reflex activation of apnea. Okay. For example, suction. So routine suction, that's why it should be avoided during delivery. Any fluid in the larynx or lung inflation or chest wall distortion, that may precipitate apnea. Okay. So these reflexes are involved in the apnea, and it is sometimes associated. For example, vigorous use of suction catheters in the pharynx or fluid in the upper airway during feeding, they may cause reflex stimulation of pharynx, and it may cause apnea. Okay. And the respiratory muscles like diaphragm and intercostal muscles are there will be impaired coordination. There will be no coordination. When the diaphragm contracts, the larynx and the pharynx should relax. So all these things are not very coordinated in preterms, especially in REM sleep. There will be poor muscle tone that may cause obstructive apneas. Okay. And nasal obstruction is very common in preterm. And whenever there is nasal obstruction, babies will not open mouth for oral breathing. Okay. So you have to clear nose. That's why I stress very much to the parents. Whenever there is nasal obstruction, the babies will get irritated initially. They may become hypoxic, and they may even throw seizure also, just because of nasal obstruction. Sometimes you may not get any reason for the seizures in a neonate. It will be only a nasal obstruction and causing hypoxia and seizure. Okay. So we have seen quite a few neonates where they will be coming with seizure, and they will tell the baby struggle to breathe and all, then subsequently throwing fits, all workup, MRI, your metabolic workup, everything is normal in such neonates. CSF, everything is normal. So gastroesophageal reflux occurs in preterm infants, but there is no role of any anti-reflux measures to prevent apnea. So usually apnea itself causes lower GER, gastroesophageal sphincter tone, and then it will cause GER. Not like GER causes apnea; it is the other way around. There will be prolonged apnea, there will be hypoxia, there will be loss of gastroesophageal sphincter tone, then there will be GER. So don't think that adding anti-GR measures like Domstal and all will prevent apnea of prematurity or desaturation. Okay, it is even proven by many studies. Okay, so many inhibitory neurotransmitters are also play a role in pathogenesis. And then is intermittent hypoxic episodes. Some babies will be chronically hypoxic. They will be desaturating, but they are self-resolving. You need not stimulate the baby. 87, 84, 83%, they will come down and they will go back to their original saturation above 90. So this is because of immature respiratory pattern and or periodic breathing that will be occurring. So these are very common in preterm that will usually continue till term equivalent age or some late preterm ages. So it is not known what is the long-term consequences of these intermittent hypoxic episodes. So you need not treat them with oxygen always. Sometimes you may not shift the baby out of ICU because of this intermittent hypoxic episodes. Baby will be self-recovering, no distress. Just because of desaturation, you're keeping the baby in ICU. That is not the thing. Okay, it will not even respond to oxygen also, and you will unnecessarily will be causing oxygen toxicity and ROP. Okay, so all babies less than 35 weeks need monitoring for apneic spells at least during the first week after birth. Okay, till when you should monitor? So at least during first week after birth, all babies less than 35 weeks you have to monitor. Okay, so when you should monitor, if there is already an apnea to the baby, when you should monitor at least apnea free for 5 days. Okay, so and what you should use for monitoring, pulse oximetry you should be used to detect episodes of desaturation, and there are some apnea monitors also available, and you should promptly respond to alarm, and also remember to respond to the infant. Okay, check for bradycardia, cyanosis, airway obstruction. So what should you do when you so the question will be asked, there will be a baby preterm 29 weeker or 31 weeker. So what you should do when you see a baby present with apnea? So what you should always check or you should write is, you should anticipate apnea in such baby, and you should monitor for apnea in first 7 days. That is when the apnea happens. So you should put the monitor. So you should always, when the monitor sounds an alarm, you should respond to the infant, and you should always check for bradycardia, cyanosis, and what type of breathing, whether there is any obstructive apnea is there or not. Okay, so you should give tactile stimulation to the soles. So most apneic spells respond to tactile stimulation. So once there is tactile stimulation, what you should do is, then you have to identify the cause, search for the cause of apnea. So if the baby fails to respond to tactile stimulation, you should start ventilation with bag and mask ventilation. So how much FiO2 you should use for bag and mask ventilation? Suppose the baby was in room air in your postnatal ward, don't connect oxygen and do bag and mask. So you should use the same FiO2. For example, you should use AMBU and do with the room air AMBU only. Okay. So for example, if you use FiO2, higher FiO2, you should be you will be causing elevated arterial oxygen tension and causing free radical injury and ROP, BPD and all. So after the first apneic spell, what you should do? You should identify the cause. So what are the causes for your apnea? That's what we should read now. Okay. So always evaluate the cause. Ask for the history. Who saw the apnea? What was the baby doing during apnea? During feeding it occurred, or was the baby supine or the baby prone? How was the neck position? When was the last feed given? Was there a vomit in the mouth? Was there a seizure occurred during that episode? Or what was it? All these things you should monitor. Okay, so what you should send is investigations. Okay, so after history and physical examination, you should send investigations like blood gas, CBC, and blood glucose, calcium, and electrolyte levels. So these are the basic investigations you should send, and always search for the causes. So these are some of the 8 causes that you have to evaluate in an apneic child. So these are the 8 causes. So one is infection. necrotizing enterocolitis, impaired oxygenation, metabolic disorders, drugs, temperature instability, intracranial pathology, and anemia. So these are the 8 causes. So how I remember from my MD days is, so this is a simple mnemonic. I for infection. So A is always. I always trust. Trust is T for trust. Okay. Temperature instability. Trust. N is necrotizing enterocolitis. That is N is Narendra Modi. MODI. I always trust Narendra Modi. M is metabolic causes. O is oxygenation impaired. D is drugs. And I is intracranial pathology. So I always trust Narendra Modi. Okay. I is infection. So when you suspect infection, if the baby is not looking well, feed intolerance, lethargy, temperature instability, shock, and sugar disturbances are there, you have to investigate for infection. So what you should send: blood culture, urine culture, CBC, CRP you should send, and start on antibiotics. So I for infection, A for anemia, always. A is always. So if there is blood loss, pallor, you should do hematocrit and transfuse. If there is within the cutoff, you have to transfuse. Always. Trust is temperature instability. If the baby is exposed to cold environment, then there will be lethargic baby, not moving. Then there will be, once you warm, the baby becomes active. That is temperature instability. Trust. Narendra is in necrotizing enterocolitis, feed intolerance, GI aspirate, abdominal distension, get an X-ray, keep NPO and start on IV fluids and antibiotics. Okay. So Narendra ho gaya. Then Modi. M is metabolic disorders. Metabolic disorders is glucose, calcium, and sodium. Okay. So check these levels. How will the baby present? Jitteriness, poor feeding, lethargy, CNS depression, and irritability. So M then is oxygenation. O is oxygenation. Baby will be desaturating, tachypneic, RD will be there. Start on oxygen. If it is more distress, start on CPAP. Do an ABG measurement. Get a chest X-ray. What is the cause for distress? If there is pneumonia, start on antibiotics. O is OF. Then D is for drugs like magnesium or any phenobarbital overdose. Okay. Baby will be hypotonic, and maternal use of magnesium and all will be there. D and I is for intracranial pathology. It may be asphyxia, IVH, meningitis, or malformations. Baby may present with seizures and all. Do see a cranial ultrasound as first level, CSF as next investigation, and then if there is no clue, then go for MRI investigation. So once the baby presents with apnea, so you have to do tactile stimulation. If the baby responds to tactile stimulation, well and good, then you work up for the underlying cause. If the baby doesn't respond to tactile stimulation, go for ambu bag ventilation with the same FiO2 whatever the baby was receiving previously. So put the baby on monitor for then you work up for the cause. Send basic investigations like arterial blood gas, CBC, blood glucose, calcium, and electrolyte levels. So once this is done, so work up for the cause. What is the cause? As I told you, 8 causes. If there is none of these causes are identified in a preterm baby, then it will be apnea of prematurity. Then the caffeine will usually work. Okay. So in other etiologies, you may have to treat the underlying etiology. You may be giving caffeine, but the caffeine will not be doing the actual job. So once the actual pathology, for example, sepsis and all is treated, you may plan to taper the caffeine even after 7 days only if you have started caffeine for sepsis baby causing apnea. Okay. Suppose some in our ICU, we have seen babies with sepsis who have been like no efforts, totally limp baby, whom we have to put on ventilator also, and 2-3 doses of antibiotics. Suddenly the next day we will be extubated and he will be self-extubating. Okay. So such will be the dramatic response of if you treat sepsis, which is causing apnea. So such babies may not need a long-term caffeine. You may stop caffeine once the baby is apneic free for 5 days. Okay. So what is the treatment? One is general measures and then is caffeine. Okay. General measures is you have to treat the specific therapy. Specific therapy, what is the underlying cause? NEC, you have to treat NEC. Okay. And if there is temperature instability, keep the baby warm. If there is drugs, you have to eliminate the drug. Okay. Metabolic disorder, sodium is abnormal. The baby is having hyponatremia, give sodium. Okay. So such we have to treat. And the optimal range, you have to maintain the oxygen saturation 90 to 95%. And you have to avoid reflexes like the trigger, like suctioning, and position of extreme flexion, extreme extension of neck should be avoided. And prone positioning usually stabilizes the baby, but it should be done with monitoring. When the nurses are there, one-to-one nursing is there, then only you may keep the baby in prone position during your NICU. Okay, only when there is not, do not advise this prone position at home. Okay, then what we use for apnea of prematurity is caffeine. So what is caffeine is? Caffeine is a methyl xanthine. Okay, how does it act? It acts by antagonizing adenosine receptors, where it antagonizes two types of receptors. One is inhibitory receptor and stimulatory receptor. Both it antagonizes. Okay, so prevents respiratory depression by blocking A1 receptor. Okay, then what are the other effects of caffeine is? It increases the sensitivity of respiratory center to carbon dioxide, and then is the decreases periodic breathing, and also it stimulates the diaphragm also. It increases the diaphragmatic contractility also. It increases the sensitivity of chemoreceptor of the respiratory center to the carbon dioxide, and it decreases hypoxic depression of breathing, and it decreases periodic breathing in the baby. Okay, and sometimes you may have to start caffeine for prophylactically also. So why we give prophylactically caffeine in a preterm is not for apnea of prematurity. You should remember this very clearly. So caffeine has a prophylactic, what when we give in first day of life, less than 29 weeks and 1 kg baby, when we give caffeine, so that is mainly given for your long-term neurodevelopmental protection, your BPD protection, your PDA prevention, and your NEC prevention. So these are the things that are why caffeine is given early days. Okay, it may not be very much helpful for preterm neonates. For example, in 32 weeks babies, early caffeine therapy within first 3 days of life seems to be beneficial in reducing BPD, PDA, and duration of mechanical ventilation. Okay, so hence it may be these Clarity advises to give in less than 32 weeks. Okay. And before extubation, always give caffeine. Okay. What is the dose of caffeine? 20 mg per kg loading, followed by 10 mg per kg or 5 to 10 mg per kg maintenance. Okay. If the apnea continues, even after this, you may give additional loading dose of 10 mg per kg per dose and increase the maintenance by 20%. Okay. And caffeine, when should you discontinue caffeine? As I told, if the apneic spells have not occurred for 5 to 7 days. Suppose you have started for sepsis baby, caffeine because of apnea, you may, if the apneic episodes have not occurred for 5 to 7 days, you may stop caffeine. And if there is apnea of prematurity, then you may have to continue till 33 to 34 weeks. Sometimes if there is baby less than 28 weeks, I told you may have to monitor beyond term also sometimes. Okay. So other things you can use is CPAP sometimes may be required, or high flow nasal cannula may be required. If there is not effective, you may have to use NIPPV also. Okay. And after extubation, you may have to switch the baby to NIPPV to prevent apnea. Okay. And blood transfusion, whether can you give blood transfusion to reduce apnea? Only if the hematocrit is less than 25 to 30% and baby has refractory apneic episodes and bradycardia, then you may try to give blood transfusion, but the studies are conflicting. GER measures, as I told, GER has no significant association with apnea. So it is not shown to reduce apnea frequency. Anti-GER measures like acid decreasing drugs, PPIs, Domstal, all these things will not decrease your apneic episodes. Okay. So sometimes you may have to give mechanical ventilation also. When you can discharge is when the baby has no apneic spells for 5 to 7 days prior to discharge, after caffeine has been stopped, then you can discharge the baby. Caffeine half-life is 50 to 100 hours. Okay. So at least 1 week after the caffeine is stopped, the effect is gone. Then the baby doesn't have apnea. So you may discharge the baby. Sometimes feeding events, desaturations will occur. That events you should not count as apnea. Okay. So feeding associated events are generally not included, like the baby has apnea. Okay. So that you should know. And if the baby has apnea of prematurity, any intercurrent viral illness, for example, RSV, if you read RSV in Nelson, it is known to cause apnea. Okay. RSV infection per se can cause apnea, and other use of anesthesia and ophthalmologic is ROP treatment or vaccinations, they may all precipitate apnea. Okay. For example, you have to monitor during this immunization period. Okay, immunizations primarily 2 months immunization and some first immunization, 1.5 to 2 months, and rarely second immunization. They may precipitate apnea in very preterm neonates. So, such neonates during their immunization visits, you have to ask them to stay nearby hospital and monitor. Okay, especially in very preterm neonates, these intercurrent viral illness, anesthesia, ophthalmologic examinations, they may precipitate apnea. Okay, so when they give approach, you start with, as I told, tactile stimulation, monitoring of apnea, less than 35 weeks, first 7 days, tactile stimulation, response, do not respond. You may create your own flow chart. This is not given in this book. Response, you have to work up for underlying cause. If it doesn't respond, go for bag and mask ventilation, sometimes even NIPPV or even intubation also. Work up for the underlying cause. What are the underlying investigations you send? What are the underlying causes? Then what is the treatment, specific therapy, and preventing apnea, and position of neck, then caffeine, then other things like your CPAP and blood transfusion, no role of gastroesophageal reflex measures, and sometimes even mechanical ventilation may be required, and when you should discharge such a baby with apnea. 7 days after stopping caffeine. Okay, 7 days after stopping caffeine, when the half-life is duration is over, then the baby doesn't have apnea. It means that the baby is apnea free. Okay, do not count the feeding associated desaturation events. Okay. Okay, so this is what is apnea and apnea of prematurity. Term baby apnea, always consider abnormal. Okay. Okay, rest of the things tomorrow we can discuss. Any doubt or anything? Tomorrow we'll discuss at the same time, 8 o'clock to 9:30. Okay, thank you everyone.